So the three topics that I'm going to talk about are the new PrEP regimens, transgender women, and PrEP, mainly around pharmacokinetics of PrEP. And I have no idea why this was interesting to me because I don't know anything about breast milk, but I just found this topic of U equals U and breast milk fascinating because it's something that I don't think about, and I just thought it was a really great topic, and I wanted to bring it up as something that we don't really discuss much at CAPS. So this is probably a slide that you've all seen. It's basically plotting out the various PrEP trials of tenofovir STC, looking at the increases that as drug levels increase, effectiveness of PrEP increases as well. And this was, I think, is kind of central for this section of the study because this is a paper that was presented at IAS last year and basically looked at how PrEP uptake has increased by about 7-fold from 2012 to 2016. So it's a really impressive increase. The problem, though, is that there's still a lot of issues and barriers around uptake and persistence. So, for example, as far as uptake is concerned, the lack of provider confidence makes that a nice way of saying knowledge. The incorrect perception of risk by the individual, frequency of the need to come to clinic visits, the lab tests, the distance to travel to get to a clinic. And then there were so many other things, I just lumped them all into one bullet, but they all deserve their own thing. So cost, partners' approval, stigma, lack of belief in the efficacy, lack of awareness, lack of confidence to speak to a provider, so fear of judgment, not having time, and then again, lack of provider knowledge that the individual perceives are all issues, barriers for uptake. And then, can we share your screen? Oh, sorry, never mind. I just got a note that didn't realize getting shared.
We missed your slides of the museum, but we could see the research stuff.
No, I'll have more, Carol. It's okay.
I know. Thanks.
More coming.
Can you see now? Who do we have on the phone? Is that
Yes.
Carol?
Yeah,
Carol.
hi. Yeah, can see it.
Okay, great.
Thanks.
Anybody else on the Zoom line? Nope. Okay.
All right. So then we have barriers to PrEP persistence, which includes pill fatigue, adverse effects from medications, and then everything else that I listed above are also included for barriers to PrEP persistence. So as a result, there's been a lot of effort put into overcoming some of these barriers by having different formulations for new PrEP regimens. So TAF, or Tenofovir Alafenamide, which I'll get into in a little bit, is one of the approaches to try to decrease side effects. But then there's inserts, long-acting injectables, implants, vaginal rings, all sorts of things that are really being researched. So pills, and the main reason is also pill fatigue, that really there's no one daily pill that's feasible for everybody or one formulation, and we just need a diversity of for choice. So you have all the photos of the various things that are being studied right now. So just a quick background, because I have to geek out with pharmacology all the time. So tenofovir alafenamide, for those who may not know, is a prodrug of tenofovir. So TDF is tenofovir disoproxil fumarate. That's the medication that currently exists in Truvada. So what happens with TDF is that it's kind of inefficient. Once it hits the plasma, it's unstable and it changes or metabolizes to tenofovir, and then a smaller amount gets taken up by the lymphocytes where they actually are active. They get changed to tenofovir diphosphate, and that's the active form. TAF, on the other hand, or tenofovir alafenamide, is more stable in plasma, and in much smaller amounts gets metabolized to tenofovir TFV, so a larger amount gets moved into the lymphocytes. So even though they're pretty much equally active, there's fewer side effects as far as renal and bone toxicity with TAF versus TDF. Oh, okay. So the TAF base regimen is currently being studied in the Discover study, and so that's looking at TAF-FTC for PrEP in MSM and transgender women who have sex with men. On clinicaltrials.gov, they said that the estimated primary completion date is 2019. I assume they probably won't be publishing results or presenting them probably later 2019 or early 2020. Just to show you that even though TAF is probably the most, the medication that's the most progressed after Truvada, there's still a lot of time before we get good data to be able to recommend it in clinical practice. So TAF has already been shown to reduce SIV in macaque models that were challenged with SIV. And then this was an abstract that was presented at the meeting in Madrid that compared TDF-FTC versus TAF-FTC, and basically showed that, as we know, of course, lower tenofovir plasma levels, so lower side effects, the short-term side effects, nausea, vomiting, diarrhea. There were higher cervical vaginal tissue levels with TAF versus TDF, and then there was protection against HIV that was demonstrated ex vivo in tissue models. And they have data on rectal compartment, but they didn't present that. They said that that was going to be reported at a later date. And then I just really like this comment from the audience. I put it here that, you know, they're basically like, let's not hype TAF as it's another marketing ploy, given that TDF is already off patent. FTC will soon be off patent, so we will likely have a TDF-FTC combination that's generic very soon, probably by 2020. And then the costs of the two are about the same now, and then long-term side effects are also pretty low with TDF-FTC, especially for folks who aren't being given other boosted drugs like a boosted protease inhibitor along with TDF-FTC. So it's also, there's this marketing issue that's happening as with all medications. So the other abstract that was presented was this vaginal or rectal Rilpivirine TAF inserts. So these are thought to be helpful because they're on demand, so the user can use them, right before, any sort of sexual intercourse. If they're user-friendly, I'm not sure why they're user-friendly, but economical, so because it's fewer that people need to use, and it limits the toxicity because you're basically inserting them right at the site of activity and fewer times than having to take a pill every single day. Rilpivirine is an integrase inhibitor. It has immediate bioavailability and it rapidly accumulates in the mucosal tissue. TAF, as we just talked about, is also rapidly converted to the metabolite tenofovir diphosphate and has a really long intracellular half-life. So that's why they combine them together. In the macaque models, this was the abstract that they presented. There was sustained levels of tenofovir diphosphate in vaginal tissues up to 7 days, and it was also detected in rectal tissues at high levels, and there was minimal systemic exposure when there was vaginal dosing, so hopefully limited toxicity as well. So what's unknown, and pretty much unknown for all the other formulations that I'm going to talk about from here on out, is that given that it's on demand, it's still unclear how early it would need to be applied for it to be considered protective. So like, is it, for example, like the on-demand PrEP regimen that has to be taken 2 to 24 hours before sex and then 24 hours later, and that's 48 hours later for it to be protective, or is it just a one-time thing? And also as far as drug-drug interactions, it's unclear, like, for example, if someone's taking rifampin, is there going to be a drug interaction with these medications that are either inserts, implants, or injectables, and how that's going to look. So moving to the long-acting PrEP regimens, so some of the problems with long-acting is that even though it's great that you do one injection and it lasts you for like 2 to 3 months, the problem is that there is it's unclear who's going to have side effects to them. So there needs to be this oral lead-in time frame, so say a few weeks where you're taking the oral medication, make sure you don't have side effects, and then take the injectable. The other issue that it does have this prolonged subtherapeutic tail. So in this graph, you can see. So as we go from low drug exposure to high drug exposure from the left to the right, we have if there's an exposure to HIV infection, there's no drug resistance, and possibly infection. Whereas on the green side, if there's high drug, there is no infection, no drug resistance, and the red zone is where we run into problems where there's this lingering amount of medication from this subtherapeutic tail, where if there is a potential exposure, there is a higher chance for drug resistance. The last issue, and probably not the only other issue, is probably a lot more, is drug interactions. As I said before, is that if someone is getting these injections and they are also on an oral medication that interacts with the injectable, what is the outcome of these two? So Cabotegravir is one of the injectables. It's an integrase inhibitor as well, and it's used as an intramuscular injection. It has a really long half-life of about 40 to 65 days. There were several abstracts. Two of them I have here. One was around the general acceptability. So it seemed to have high acceptability. There was a lot of pain on the injection site. Long half-life meant that the injection could occur at least every 2 months. And then there was high levels of protection in macaque models. As far as the tail phase, that was another abstract that was presented. The tail phase was also well tolerated, and what they noted was that women and those with higher BMI had a longer tail. So, for example, women had a tail of around 66 weeks, whereas men had 43 weeks.
What does that mean? When it has a longer tail that long, what are the implications of that?
So that was this. So the longer the tail, the longer you're in that red zone of resistance. Yeah, thank you. And then the next injectable, long-acting injectable is Rilpivirine. Rilpivirine is a non-nucleoside reverse transcriptase inhibitor, and it's also being given as an intramuscular injection. It has a longer half-life, so about 90 days. And so this was part of a symposium where they talked about HPTN 076, and I combined it here, so even though this is not brand new data, but it showed that this was safe and acceptable in HIV-negative women, and it was given as if there are two milliliter IM injections given every 8 weeks, and it was safe, acceptable, well tolerated, high concentrations in tissues. So this was one of the things that they were worried about, that there actually was one subject who developed Rilpivirine drug resistance because during that tail phase when they were exposed to HIV. So so the next category is implants. So advantages of implants is that it's removable. So if this person's having side effects, it can be taken out. That you don't have to wait 90 days to have the medication wash out or longer. It has more consistent and predictable drug release, and the pharmacokinetics doesn't depend on the injection site. So if someone has more muscle or more fat, depending on whether the medication is more hydrophilic or hydrophobic, it won't really impact the pharmacokinetics as much. The disadvantages is that it does require a specialized device for insertion, and it's a surgical procedure to remove it. And it's also regulated both under drug and device, so there's probably more scrutiny around its approval. This is what it looks like. That's not up to size. It's actually, it looks like a little matchstick. And so when it's under the skin, there's like a small, raised area. So there were two abstracts on this. One of a rabbit model, the poor rabbits. I felt so bad for them. But essentially, it was effective, well tolerated. I don't know how that was assessed. Easily retrieved after more than 60 days, and it delivered protective levels. And then they discrete choice modeling seemed to be a big thing in this, right? Everybody had a discrete choice modeling. It's like one of those where, does everyone know what that is? I didn't. It's like one of those where it's like they give you two different scenarios, like, you know, do you want an injectable or do you want an implant? And then you pick one. And then now, do you want an oral or do you want an implant? You pick one. So you go through all these you know, do you want more pain or, you know, more pills? Like, which one do you want to take? So you pick which one you want to get it to help the drug manufacturer, I guess, to also help figure out what are the best, what do people want to see as far as delivering a medication. It can also help as far as like the delivery, like, do you want to, you know, get this medication at your local pharmacy, or do you want to add it, you know, some sort of like a clinical, you know, location? So that's basically discrete choice modeling, fancy term. So that in this study, they basically examined discrete choice modeling among MSM, and they basically showed that they preferred implants over pills and injectables, and they preferred a replaceable option over a degradable option. I'm not sure why, because I would assume it'd be nicer if it just degrades and goes away versus having to take it out, but that's what this showed. Any quick questions before I move on to the topic 2? All right, so transgender women and PrEP. So Carol, this is one of the paintings also.
Thank you, Parya.
So 2 topics are the SF gaps in PrEP continuum of care and also TDF-FDC levels with hormones. So this was a paper presented by Al Liu, our own Al Liu, that basically looked at the disproportionate impact of HIV on transgender women. And basically in San Francisco, the prevalence of HIV is 32% in transgender women, 19% in MSM. So in this study, they compared 2 different cohorts. So one was a transnational study, the cohort of 368 HIV-negative transgender women in the Bay Area, and also versus the National HIV Behavioral Surveillance System is a population-based study of 399 HIV-negative MSM in San Francisco, to really look at the PrEP continuum between the 2. And so basically what they showed here in burgundy for trans women versus the violet in MSM, there was at every step of the PrEP continuum, there was a reduction of PrEP awareness, talking to providers about PrEP use, being on PrEP and adherence in transgender women versus MSM. So these are the prevalence ratios. So you can see they were all well below 1. And essentially what they also reported was that among the 54 transgender women and 159 MSM who were taking PrEP, there was also a lower reported adherence in transgender women. So the prevalence ratio in this case was 0.63. And one of the things that they were wondering was that whether this was due to if low PrEP uptake was due to low engagement in care, but when they looked at other markers of engagement in care, it was actually relatively high. So 94% said that they saw a provider in the past year, 93% had health insurance, and 74% said that they were currently using hormones. So their conclusions was that they compared to MSM transgender women had multi-level gaps in PrEP continuum despite being engaged in care otherwise. That the disparities in that they saw in the PrEP continuum may also reflect either earlier marketing efforts targeted towards gay men, the intersection of racial and gender-related stigma that transgender women face, and then medical mistrust. So their final conclusion was that we just need more targeted efforts to address increased PrEP awareness, provider outreach, and trust for PrEP uptake and adherence for transgender women in San Francisco. So the next section is around PrEP pharmacokinetics in transgender women. So there were 4 studies that just in the symposium were discussed, and I just kind of summarized all of them to get to the final conclusion. So one was IFAC study where they looked at TDF-FTC in 20 transgender HIV negative individuals, and basically they showed that TDF exposure was 13% lower, had 13% lower AUC, or area under the curve concentration, when it was given with estradiol. And AUC is just a measure of exposure, so how much are you exposed to medication? So 13% lower among transgender women. And then there was no change in the feminizing hormone therapy, with TDF-FTC. So that was good that there wasn't a reciprocal lowering. There was a second paper on 4 transgender women and 4 cisgender women living with HIV, and they basically looked at a variety of levels. I'm actually not sure what the tenofovir diphosphate ratio with DATP means, and they didn't describe it, but it was 8-fold lower in transgender women. The absolute tenofovir diphosphate levels were similar, so that's good because that's the active component. But they did say that the lowering of this ratio wasn't associated with higher HIV RNA or DNA in the rectal tissue, so that's also encouraging. There was in the same line, there was an abstract of 8 transgender women and 8 cisgender men, and they basically also showed that the plasma tenofovir and PBMC tenofovir diphosphate AUC in transgender women was lower by 31 and 33% respectively versus cisgender men, and the plasma tenofovir FTC AUC was also lower in transgender women. The median colorectal cell tenofovir diphosphate and FTC triphosphate were also lower in transgender women. So the summary of all this was that in transgender women, tenofovir and FTC plasma and colon tissue cell concentrations are lower. The clinical implications are unclear because it's unclear if that lowering is enough to decrease protection, or is this still within the protective range. And then, so basically what the speaker said, that until we have further data from larger studies, we should basically be tentative, have caution with lower doses. So for example, the Ipergay dosing, or the on-demand dosing that I noted earlier, of 2 doses 2 hours before effects act and 24 and 48 hours later. I should also just mention in the Lancet HIV article that our own Jay Sebelius is a co-author on, they actually did look at tenofovir levels, and they said that in transgender women who took 4 more doses per week, they had enough protection. So unclear, but maybe this targeted dosing from Ipergay we need more data around. All right, U equals U and breastfeeding. Yeah, so this is very interesting to me because, yeah, breastfeeding is something I never talk about. So ART doesn't eliminate risk of HIV transmission through breast milk. So there was a PROMISE trial, 2,430 infant mother pairs that were randomized to the maternal ART or infant nevirapine, and they basically showed that transmission was 0.6% with 12 months and 0.9% with 24 months of breastfeeding. 2 out of the 8 women on ART who transmitted had confirmed undetectable viral load. HPTN 046 trial also showed that healthier mothers, so CD4 cell count greater than 350 on ART, had lower risk of transmission, so 0.5% in women on ART. And there was one meta-analysis of a bunch of these trials that showed 1.1% transmission at 6 months and 2.9% transmission at 12 months on ART. So this is what I found fascinating. There's 2 forms of HIV in breast milk. One is the cell-free virus, which is viral load, and that can be eliminated with antiretrovirals. And then there's the cell-associated HIV DNA that's found in immune cells, and ARVs are not good at eliminating that. And so babies drink about 3 to 4 cups of milk per day, and that's about 1 million immune cell exposure per day. and breast milk activates immune cells, so they're 10 times more efficient at HIV replication in milk versus blood. So breast milk has a lot of cells that harbor HIV RNA and DNA, and the virus-activated CD4 cell and latently infected CD4 cells can pass from blood to milk. And on top of that, ARVs have different ways of passing to breast milk. So NRTIs and NRTIs pass okay, protease inhibitors don't. Integrase inhibitors we don't have very good data for. So there is this lower concentration of ARVs that can actually harbor drug resistance as well. So drug resistance can also be transmitted to babies. So the take-home point was that U does not equal U for breastfeeding. So the more HIV cells in breast milk, clearly the higher risk of transmission. So for every log increase, there's about a threefold increase. Every log increase in infected cells, there's a threefold increase in risk of transmission. And the things that are important is breast care because of the inflammation of the mammary glands, how do I have? Adherence, and also adherence is an issue because of lack of sleep, depression, and being more vulnerable if there's lack of support. So the take-home point was that the context is important, so it depends on the low versus high resource settings. For US and Canada, there's a recommendation against breastfeeding, whereas for lower resource settings, the transmission has to be balanced against malnutrition, diarrhea, and pneumonia that the baby may experience without breast milk. So that was super interesting. That's my last slide. This is from Man Ray. Super cool.
Thanks so much.
We'll move on to Jen.
Just to let everyone know, there's nobody coming into the room right at once, so if we need to go a little bit over, I don't know.
Hopefully not. Monitor my time. So thanks everybody. So my talk, I basically reached out to the people that who presented that I thought had interesting talks on a variety of topics. So fortunate enough, they just gave me their slides. So I edited them down to a couple of the key findings. So they're my edits on these people's slides. So so yeah, hopefully they don't find that offensive. So to kind of step back and look at the larger picture, this was a talk by Laura Fitch, who was talking about this program called it's the global tracking of PrEP provision. And so they were making the argument here that we have this fast track goal to get 3 million people on PrEP or with access to PrEP by 2020. And that's about the goal is to get 75% reduction in new infections by that time. But we don't have a good way to look at all of the different programs that are in place around the world to provide PrEP. And one of the key problems they talked about was this sort of decentralized nature of like how people monitor PrEP in charts, in studies, and demo projects. And that if we don't have a clear understanding of who's getting PrEP, where is it being provided, then we can identify these gaps and trends over time. And so this is an online, the Global PrEP Tracker is an online database that you can submit if you're doing a PrEP study. And they reach out to researchers all around the world to provide this kind of scripted data of the country, the target date, types of projects, frameworks, etc. So you can go on there and kind of look at different outcomes across different regions and countries around the world. The only thing I'll focus on here is that North America is leading in the total number and the proportion of the targets that we've hit. There was about 220,000 PrEP initiations have been delivered in 2018 or up until 2018 in the first quarter. And so the next level is sub-Saharan Africa, but then there's a big gap between how many they want to initiate, which is 141,000. And so there's some issues around who gets to say what our target numbers are, and this is what they were claiming, based on the funders might want to see, X amount of initiation, and so there's some gaps there. And so, yeah, they were just basically saying North America leads in the number of PrEP across the country, 71%, followed by Sub-Saharan Africa, And the key points here was that PrEP continues to be dominated by MSM. And I thought for issues of sustainability and scale-up, what was interesting was that 71% of programs were for MSM and implementation projects. And so there's this issue of when you compare that to sub-Saharan Africa contexts with adolescent young girls and women who are accessing PrEP through research and NGOs. So how are we going to kind of hit those targets moving forward without a sort of a long-term plan for either research or implementation science? So yeah, so I thought that was kind of interesting. And so the next talk, which Parya kind of had a nice intro for setting this up, was given by a biostatistician at University of Washington, Deborah Donnell. And what I found fascinating with this one was this sort of bigger question we have is that, as we talked about, there's new choices that people are working on for PrEP, but inevitably they're going to run up against this barrier of going against the standard of effective PrEP that we now have. And so what does that mean for intervention and clinical trial designs from a truly methodological perspective, right? So there's new orals that Parya talked about, microbicides, vaginal ring, injectables, implants, etc. So the goal now is, with all of these new products on the left, is how do you create a new agent that is at least useful, if not more beneficial than what we currently have. And so what this does is it creates a problem for sample size, really. So her talk was in the context of bringing a product to market, right? So it needs to be safe, effective, there needs to be high standard of evidence, but because PrEP is so effective, it's obviously contingent upon adherence to it, that these new drugs need to be even more effective and with extremely large sample sizes. So she talked about there's going to be kind of 3 new trial designs. One of them is where you're comparing a new product to FTC-TDF. Another design is where you're layering a new type of PrEP product to a placebo that is on top of PrEP. And then there's this combination where you're combining multiple prevention options for people. And so what she was highlighting here was there's this ongoing trial, HPTN 083, showing that if they're assuming that this long-acting injectable is 25% better than PrEP with a 2.1% incidence rate, which is current, you're going to need about 4,500 people. But what over time, as you know, we focus on issues of adherence in PrEP, and if injectables become kind of a standard, incidence is going to go down. And so therefore, if you have a new drug that's similarly effective and you're trying to compare that to PrEP with an incidence rate of 1, you're going to need about 40,000 people. And so basically, we're going to run out of potential subjects to test all of these new drugs. And so this has to do with issues of specifically non-inferiority trials, which kind of depend on reducing new infections. So they gave some solutions to modify our statistical approaches, which they went into a big, long ordeal about, which I'm not going to focus on. The other thing they talked about was integrating or nesting multiple questions within a trial. So not just is this drug superior or non-inferior to PrEP, but if there's multiple different types of sort of behavioral questions that can be asked. And I think that the final interesting part was modifying the population. And so they outlined this design where if someone's willing and able to take current PrEP and it's effective, then you would randomize them to either PrEP or this new drug. If they aren't able to take the current standard, you could then randomize them to a placebo, because you need to address the issue of clinical equipoise, but that's also assuming that everybody's able to take the standard. And what they were arguing is not everybody is able to take PrEP right now, or want to. And so therefore that may give you equipoise to randomize them to a different condition.
But you still can't compare them, right?
Yeah. Or the other option is, if they are, you just put them in an observational trial. And if they're not, then you can assign them to different conditions or different new drugs. So this is one way they're thinking about getting around this issue. To give Kim time, I might do one, two, maybe two more. Okay. So this one's from Matt Spinelli, and everybody here at San Francisco. He was looking at PrEP interruptions amongst 15 clinics here. And so his aims were to characterize the patterns of persistence of who stays on PrEP and who discontinues from PrEP, or what are the predictors of persistence and discontinuation. And he was also looking at predictors of poor retention, specifically related to PrEP. And then care utilization while on PrEP, as Parya was mentioning, folks with the transgender study, these folks were engaging in medical care, but not necessarily engaging in care around PrEP. So this is what Matt was trying to understand. So they looked at data from January 2017 across 15 clinics, and they basically did a medical chart review and got out all the information they needed. There had a couple of different outcomes. The primary one was whether you stopped PrEP after 90 days. This is late discontinuation, or before, so it's early. And the primary predictor was if they missed any visits in the prior PrEP use quarter. And so they also had some PrEP care utilization variables. So they were looking at those who were on PrEP for a year who attended all visits in 4 quarters of the year. They looked at gaps in PrEP use for 90 days, not taking gaps. And to get at that other point of if folks are engaging in care, but not necessarily related to PrEP, which he calls missed opportunities. So what they found since 2017, or it's about a year, they had 364 people initiate PrEP. 16% dropped out after 90 days. And then there was another drop from 55%. So only 138 of the 364 initiated PrEP remained on PrEP at about the review end, which is about 8 months. So there's a pretty big drop off there. More importantly, of those who were on PrEP for a year, about only 1 in 3 attended all 4 visits during the year. And so, more importantly, I think what Matt's take-home point here is that 68% are accessing clinic services during these gaps, but half of the time PrEP is not being discussed. So these patients are coming for urgent care visits, for mental health visits, for a variety of other things where PrEP is not being discussed. So there's clearly kind of an intervention that I'm sure he's working on to address this gap here. Just a couple predictors he presented that trans women who have sex with men versus just MSM were twice as likely to stop PrEP early here in San Francisco, those who reported drug use. And the biggest predictor of late discontinuation of PrEP in San Francisco was whether or not they missed a PrEP visit. And then he looked at discontinuation reasons. And so a lot of folks, or I should say in the charts, most of the reasons why people were missing PrEP visits were not discussed. Some had some structural issues of cost and difficulty getting to the clinic, but there is this really big unknown, and there are a few people reporting, understanding they may have a decreased risk at that time or side effect concerns. So, in conclusion, only about 38% remained on PrEP at the end of this study here in San Francisco. So there's still a lot of work to be done in this area. And so, for the sake of time, I'm going to pass it over to Kim because I want to give her fair time.
That's fun. Spread that to work. Okay, so I'm going to cover the headlines. Parya gave us a lot of detail on a lot of different studies. I'm going to give you headlines really only from about 5 to 7 studies. These all come from the social and behavioral track. And yes, featured here, I was at the Reina Sofia Museum as well.
You took that photo?
I did not take that photo. These are courtesy Google Images. Guernica, for those of you who can ever get to Madrid, if it stays in Madrid, it is such a moving and powerful experience to see this art. And I just want to say that art and science go really well together. Oftentimes we are going to conferences in these great cities with great Okay, so I am going to talk about PrEP effectiveness, uptake, and persistence. I have a couple of other sort of interesting studies that I thought maybe would be useful for you all to hear about. What I want to say is that the organizers of the R4P conference have done an amazing job documenting the science at this conference in 2018. You can look at every session. Every session is posted on their website. You can view the speaker, or if you don't want to view the speaker, you just want to look at the slides and listen, or if you just want to look at the slides, you can do that. So you can virtually attend this conference right now, asynchronously. And there was an option. I presented a poster. All people who presented posters had the option to upload their posters. So not all posters are there, but there is a great deal of information on the web. And I think it's sort of unusual. So the slides that I am going to present, I did not contact the authors as John did. So I basically just used the slides that were on the web, so they're in the public domain. Okay, so I think our areas of interest in where we're presenting dovetail well. The slides I'm going to present on, in particular, I think connect well to what John was talking about. But yeah, so let's start with what is going on sort of worldwide in terms of effectiveness. And this is a study that was presented by Jared Baden, collected data from 46 different studies. So we've known for, let's see, we're in 2018, we've known for 8 years through the IPREC study that Truvada is efficacious. So we've had the efficacy data. We're finally moving into a period where we can establish effectiveness. So efficacy is established in randomized controlled trials. We move to effectiveness, and this is a question of what happens in the quote-unquote real world when we leave the RCT's preciousness and move into demonstration projects. These 46 different studies come from demonstration projects. They represent 10,609 persons. Included in those 10,609 persons are about 200 and, Xavier, help me out, 230 people from our Oakland demonstration project. Majority male, good spread on the age. What did they find after pulling all of this really incredible data? Okay, so total of, a lot of person years. And I want you to make a mental note of this, that 62% of people in these demonstration projects persisted on PrEP for 6 months or longer. That's important to consider because effectiveness, which is measured in demonstration projects, are also kind of conditions. So that the persistence is pretty high, 62%, I'll tell you it's pretty high. So how many people seroconverted while in a demonstration project? There were 91 seroconversions. That's impressive, right? Of those, we're really focused on these 64 infections, and of the 64, 17 people may have been in the acute phase. But 64 people had been exposed to FTC, TDS, been spared from HIV. So my blood spot data, this is the biomarker for us to understand, well, were these people who seroconverted unlucky and they were considered PrEP failures? Does this mean that PrEP doesn't work for certain people, or were they not taking their medication as prescribed? So the dried blood spot levels can tell us that, and they had dried blood spot data for 49 of those people. So it's, incomplete data set, but it's still very robust. And of those 49, it looks like 2% had drug levels that were consistent with 4 or more doses per week, which we know is very useful among people who are having anal sex. So if you're having anal sex only, 4 doses of Truvada, I think we're all pretty convinced that that is a safe thing to say. So 2%.
So one person.
Tell me, all right.
49 people.
Good, thank you. All right. Summary across these 46 studies in varied populations. Yes, this is pulling data. I mean, most of the data come from North America and South America. The anti-PrEP open label extension form that distributed many studies. But, you know, incidence among persons dispensed PrEP was less than 1% per year. Okay, let's move to the United States. So John Brooks, does anybody know John Brooks here from the CDC? John Brooks. Okay, we do not study drugs. Most of us are not drug substance use experts. John Brooks at the CDC is very focused on drug use. And I can tell you that there was hardly any information. Carlo did have a poster, thank you, Carlo, that addressed substance use. But substance use is not a part of the conversation at this conference. So when I saw John Brooks, I thought, what the hell are you doing here? John Brooks was there on behalf of Dawn Smith. This is Dawn Smith's work. She is one from the CDC who is tracking uptake of oral PrEP in the United States. What does PrEP uptake look like? We've seen very fast of PrEP over the years. There are now, based on a study presented by the WHO at ARV-4P, which I won't talk about, there's about 135,000 people thought to be on PrEP in the United States right now. The age distribution is pretty good. It looks like it's predominantly going to younger people. Cool. But according to John, according to Dawn, it's not PrEP. We're not getting PrEP where we need it most. And where we need it most among young men who have sex with men who are of color, right? So the overall rate of uptake in the United States among MSM, it looks like 9% of those who are indicated for PrEP are receiving PrEP. So these numbers are good. Uptake is good, and it's steadily growing, but we are very far being where we need to be. So PrEP persistence, this is a very big and important area of interest in the field. It's also, you know, people talk about it in terms of retention. So these data come from Fulton County. Fulton County is in Georgia, in the Atlanta area. There's something very specific that I want to draw your attention to. So at 6 months, I'll get you 6 months. Here we are, 6 months right here. 6 months PrEP use was around a little over 20%. That is this. We have data. I'm going to show you data from other studies about where we are with PrEP persistence at the 6 month mark. About that. Oh, I know what I was wanting to tell you that, because in Baton's study in the demo project at 6 months, there was 62% of people were persisting on PrEP. In Fulton County, we're hovering around 20%. What is going on? We really need to figure out what is going on. People not want to persist. I mean, John just showed you some reasons about, based on chart review, what's going on with people in San Francisco, but this is an area that's really ripe for study. So now I want to take you to Kenya. Kenya is where the Partners PrEP study was done, and this was a study presented, Ken Wanya presented on what's going on in Kenya. So Kenya's doing a great job in terms of PrEP uptake. This is not in demonstration projects. These are in clinics and family planning centers throughout the country. So they were pretty impressed. They're happy. This is a high uptake over a very short period of time. So Kenya's doing quite well. In terms of continuation, right? PrEP persistence, continuation, retention, whatever you want to call it. At 3 months, 65%. So in Atlanta, the 3 month mark, 40% of people who are non-Black MSM were persisting, and of Black MSM, 30% were persisting. So these are really sharp contrasts, very different populations, sharp contrasts. This is where we need to be focusing. Some of us, I would, in particular, I'm very curious about why people aren't continuing. Host of reasons here. Client's request comes up at 70%. What does that mean? What is the client's decision is client's request? I don't know what it means, but I think we need to explore why, you know, what's going on with decision making, what motivates people to continue. I want to just very quickly tell you about this very important and cool study, a modeling study out of Atlanta, definitely focusing on Atlanta here. So this was a modeling study that is really trying to assess what is it going to take to reach the 99 targets in Atlanta, Georgia. So in the HIV prevalence in Atlanta for MSM is 34%. Parya told us what the prevalence among transgender women in San Francisco is. Did anybody remember that number? Yeah. So Atlanta is suffering, right? That's a high prevalence rate. So what will it take, given this high prevalence rate, to reach the 90-90 goal in MSM? Well, what is it going to take in terms of scaling up ART versus what will it take in terms of scaling up PrEP? So probably no surprise, we really need to simultaneously be scaling up both ART and PrEP to have the sort of quickest and most substantial reduction in HIV. Anyone who's interested, please go and dig into the details on this. The poster session at this conference is fantastic. They leave the posters up for 3 days. They give you a lot of time to mill around on your own in the peace and quiet to take in the information. It's really great. There are 2 studies that I just wanted to point to, which I'm not actually even going to tell you about, except in the bottom right-hand corner, Jonathan Volk from Koester presented really great data. I'm going to ask him to come and present to us during the town hall, so I'll see if Jonathan can come. These 2, just to advertise for them, really important renal function study, research done out of WashU, Rupa Patel, and then Meredith is a woman that I met and ran into in the airport. She was looking at PrEP use in the southern U.S., so that's great. Yes, plugging for Cape Town, South Africa. There was music at the conference, great conversation, and I just want to say really for all 3 of us, thank you to the CAPS-PRC leadership for helping us to get to the conference, and certainly thanks to all of the prevention scientists. Many of you are in the room working to put this research together. And there we are. The evidence of a good time. Wait, I have to tell this funny story. All right, that's Parya's husband. I didn't know Parya's husband, and Parya wasn't there when I got there, and so he introduced himself as a spouse of someone at CAPS, and I said, well, who's your husband?
Thank you, guys. I know that we are almost out of time, but what I was wondering is if you could shout out a few keyword take-home messages from the conference. I mean, as I think back to the conference and what I heard, I just kept hearing talk about choice. Choice came up so many times. We have an ever-growing array of options for PrEP in particular, and really the point that it's one solution doesn't work for everyone, and that choice is incredibly important. And I was very happy to hear that come up so often from so many different people. And I'm wondering what other topics, what other big picture messages you're taking from it.
I can talk all about vaccines, lots of work presented on vaccine. I think there was a lot of excitement about where we are in this era of the vaccine history, and Tony Fauci did a great kind of historical overview of where we've come and where we are with vaccine research. I would really encourage you to check that out if you're at all interested. I think you and I would be that knowledge. But I personally was really struck by and happy about the enthusiasm and optimism around vaccines.
I would say I would agree with choice, and I think it kind of brings in what John was saying about it's going to be so much harder to get a lot good data on a lot of these new methods for PrEP. So trying to figure out how we can use what we have, taking into account choice. So like, what does on-demand PrEP mean for women? What does it mean for for various populations, and how we can tailor what we have to meet the demand that. The choice that needs to go into it as well.
And I would just probably close with saying that I think they're still going to run into all the challenges that we've known forever about acceptability, feasibility, perceptions, barriers. So thinking through trying to be prepared for those challenges to respond kind of urgently rather than waiting to figure out, oh, there's a gap and this is something. So
one other thing that jumps out at me is like all this, like when we talk about persistence in PrEP, people staying on it for 6 months, we're making a big deal of that, but that's nothing. I mean, that's, I guess, it's important that they reach 6 months, but we're talking about, a lot longer period of time. And so there's a lot to be figured out to help people stay on it longer. It's going to work. Again, thank you all, and we look forward to your report backs from Cape down to 2 years. If anyone want to go report back, please do. Thank you very much. And if anyone has trouble finding the materials online, reach out to any of us and we can help you scoop it out. So, thank you guys.